So to introduce Dr. Bader and Dr. Zuckerman, Dr. Bader is the Chief Clinical Officer of Hackensack Meridian Health. He previously served as Chief Medical Officer and attending physician and chair of obstetrics and gynecology at Crozier Chester Medical Center. He is board certified in obstetrics and gynecology. He completed his residency at the Hospital of the University of Pennsylvania, as well as a fellowship in the Robert Wood Johnson Clinical Scholars Program. He received an award for outstanding performance in obstetrics and gynecology from Georgetown University School of Medicine, the Excellence in Teaching Award from the Association of Professors in Gynecology and Obstetrics, and the Sylvan Eisman Outstanding Care Physician Award. Dr. Jerry Zuckerman is a board-certified infectious disease physician who specializes in hospital epidemiology, infection prevention, and patient safety. Dr. Zuckerman currently serves as the Hackensack Meridian Health Network Vice President for Infection Prevention and is an assistant professor of medicine at the Hackensack Meridian School of Medicine. Previously, he served as Chief Quality Officer and Medical Director for Infection Prevention and Control at Einstein Healthcare Network in Philadelphia. Dr. Zuckerman is an alumnus of the University of Pennsylvania and received his medical degree from Cornell University Medical College in New York. He completed an internship and residency in internal medicine at Temple University Hospital and both a clinical and research fellowship in infectious diseases at the Hospital of the University of Pennsylvania. Welcome, Dr. Bader and Dr. Zuckerman. I'll turn it over to you.
Thanks very much. And I'll turn it right over to Dr. Zuckerman to lead us.
Okay. All right. Thank you very much. Boy, you talk about residency and fellowship. Boy, those were simple days back then. So I'm going to try to share my screen. And, do you see my screen?
Yep.
Okay. Okay. All right. So thanks everyone for joining the call. Thanks Melanie, Pat, for having us back. So you know, as Melanie said, things change and are constantly changing, and even the stuff that I talked about last month, or some of it is already outdated. So I'll give you a brief update as to where we are in terms of COVID-19 trends. Provide some updates around vaccines, and then talk a little bit about this community risk levels. This is kind of a new CDC measurement of activity in the community, and which will help, helps local areas to define, their masking guidelines, et cetera. So this is looking at the pandemic since that began first in February of 2020. We just celebrated our 2-year anniversary in New Jersey. I think the first case was March 4th at Hackensack University Medical Center in New Jersey. And we've been several surges since then, both in the country and in the US, but you can see our last, this was last year in December 21 and January 21. There was a surge then. This was due to the Alpha variant. I'll talk a little bit about that. And then in September of October, we saw another surge, and that was due to the Delta variant. And then most recently has been the Omicron surge, which you can see caused a tremendous number of infections throughout the United States. And we have peaked and have trailed off significantly since then. And so we're currently in kind of our low period. Concomitant with the number of infections, you can see that there's also an increase in hospitalizations and ICU stay. The Omicron variant, a lot of the narrative was, well, it doesn't cause as a major significant illness, that is much milder compared to the previous strains. But when you look at, the number of cases that were reported per day, and they approached 800,000 cases per day, just by the sheer numbers, you're going to have a very high number of people in the hospital. And so even though it is sort of a milder disease, the number of hospitalizations really was higher than that what we saw the previous year. And a lot of the healthcare systems were certainly inundated with COVID patients, but unlike the previous year, a lot of healthcare workers were getting sick too. So this had a significant impact on our staffing because they were getting it in the community just like everyone else. So what's happening in New Jersey? This also shows kind of the trend since the beginning of the pandemic. And our peak was in, I think it was like January 7th or 8th with the Omicron surge. And you can see that we've really trended down significantly. We're not at the lowest levels, so there's still disease in the community going around. And as of, I guess this was yesterday, we're averaging about 1,000 new cases in New Jersey each day. The thing that I watch is what's called the infection rate. So this is kind of a measure of, if one person gets infected, how many other people will get infected from that person? So what's the transmission to other individuals? When it goes above 1 means that we have an expanding number of infections in the community. When it's declining and goes below 1, then we have, things coming under control. And you can see that for each time that it started rising from green, we started to see an increase in another surge. We saw this surge here, a slight, not as much of a decrease in the fall, but another surge. And then this was the Omicron, and here we are. And the thing that worries me a little bit is that we are beginning to see that trend upward, meaning that maybe there's increasing transmission in the community. It's not something that is being widely seen, but it's certainly a marker to keep our eyes on and to be cognizant of as we prepare for any future increases in COVID-19 cases. I just wanted to show a little bit of the impact on this is looking at hospitalizations. And for many respiratory viral diseases, this tends to be more impactful on older individuals. So the individuals, this red line here represents individuals who are over the age of 65. And you can see that they had the highest hospitalization rates compared to other age groups. And then the next highest was the 50 to 64 range, and then decreased as you got younger. So definitely a reason for older individuals to be very cognizant of their exposures and ensuring they get protected and with vaccinations if possible. This was also hospitalizations were also related to ethnicity. And what we saw in this latest surge, that there was a really big increase in hospitalizations in the Black community, much higher than was seen in previous surges. And then we see in the Hispanic, Latino, and the non-white, these are the other charts, graphs, lines that we see here. So sometimes it is a disease that's occurring or affecting certain populations more than other individuals. So what are these mutations? What are these variants? And the virus wants to do one thing. It wants to survive, and it wants to, and that survival occurs by us spreading it from one person to another. So that continues to be transmitted and to live in the environment. The other way it can survive is that it evades our immune responses. So if I was, if I had certain protections against this virus and it killed the virus, then it wouldn't continue to replicate and survive. But if the virus changes a little bit so that my antibodies can't kill off the virus, it continues to survive, and then we can see the virus can continue to replicate and cause infections. So this occurs when the virus reproduces and some of the genetic code. Sometimes there are little mistakes in that code when it replicates. Some of it is significant, some isn't significant. The ones that we worry about is when it increases the transmissibility of the virus and when it evades our immune system. And this is just some schematics. This is what was called the alpha. This was the variant that was around in January 21, December of 2020. They're just showing here where the mutations are occurring in the virus. This is the spike protein. But what I really want to show here is this is the Omicron variant. And you can see you can just see there's so many different new colors in here, right? And that was what was so spectacular about the Omicron surge, was that there were a significant number of mutations in the virus that both made it more easily transmissible between individuals and also made the virus evade our immune systems better. And that's why it was so successful in replacing the other variants that were circulating and cause such widespread illness in our communities. So this is what looking at. I showed you the trends of COVID-19 in the U.S. and New Jersey. So, we have to look at what's happening in the rest of the world. And what's emerging is we're seeing an increase in Europe. So you see Germany, France, United Kingdom, and Italy are all having an uprise in their number of new COVID-19 cases. So this mini increase is due to a variant of the Omicron variant. So it's a subvariant of the Omicron. It's called the Omicron BA2. And that's predominantly what's driving these increases in Europe. And what Dr. Fauci said at Congress the other week was, we need to be careful because our experiences have been what occurs in the UK generally happens here 3 or 4 weeks later. And so this may be an omen of what's coming. It may not, but that's been our experience in the past, that the UK predates anything that occurs here. And this is just a looking, so in New Jersey and actually in the United States and many other countries, they look at the virus and they type it, identify it to see what strain it is. Is it the original strain? Is it what variant it represents? So going back, this blue here represents that alpha variant that I was talking about. Brown represents the Delta one. And you can see that the Delta replaced all the other variants that preceded it, meaning that it had an advantage over any other variant and became the predominant one. And then Omicron emerged, and because it was, even better at surviving, it replaced all the Delta variants. And so that's why we only had Omicron circulating around. And now this is where we've seen that subvariant, the BA2, beginning to emerge. And, we'll see whether it totally replaces Omicron or not. In terms of vaccination, there's been some updates, which I'll go into. These are the 3 vaccines: the Pfizer, the Moderna, which are messenger RNA vaccines. The Johnson & Johnson is a different mechanism. These are the ages that they are approved for. So Pfizer is the only vaccine that is FDA approved for children. The other ones are only approved for 18 or older. The Johnson & Johnson has a one-shot series, and the messenger RNA ones is a 2-dose series. So it requires 2 doses to be considered fully vaccinated, as opposed to 1 dose with the Johnson & Johnson. And then most recently, it's been recommended that individuals get a booster shot. And this came out during right before the Omicron surge. it was when it was first recommended for select populations, and then quickly when we were dealing with Delta, it became recommended for all adults and then anyone over the age of 12. And so it's a booster dose to help kind of stimulate our immune system to produce higher antibodies to help protect us from getting infected. And some of the terminology has changed. So what the CDC is using, it's called up to date, meaning that the person is current with all the recommendations for him or for her. So for someone like me, I had 2 doses of the Pfizer vaccine, and then I got a booster dose. So there are 3 doses of vaccines that have been recommended for me. I got them all, so I am, quote, up to date, as opposed to what was called fully vaccinated before. That's only when it's just the first 2 completion of the primary series. There was some reports of myocarditis. Myocarditis is inflammation of the heart muscle. And what was seen was that this was most common or more common in males, younger males between the ages of 18 and 30, and was more common after the second dose of the messenger RNA vaccines than the first dose. And this has been reported throughout the world. And the rates you can see here, about 40 up to 140 cases per million vaccine doses. So it's a relatively very small number of the number of vaccines that are administered. And more recently, it appears that the risk is slightly higher with the Moderna vaccine than the Pfizer vaccine. And that one measure, or one way we could reduce some of that risk, is by lengthening the intervals between the first and the second dose. So with Moderna and Pfizer, they're recommended to give at 3 weeks and 4 weeks. But what is now recommended is extending it out to 8 weeks, which lowers the risk of having this heart inflammation. So that's you can see here, this is that recommendation where they say to hold off for 8 weeks, but that doesn't mean for everyone. So if someone is at significant risk for developing severe disease or complications, you want to get them vaccinated and protected as quickly as possible. So you would still administer it according to the 3 or 4 week interval. That applies to older individuals, or if there's really tremendous amount of disease in the community, like we saw with Omicron, because if you waited 8 weeks, you most likely could have gotten infected during that time period. The vaccines continue to show tremendous value. And this is looking at cases, just all cases. The black line here represents unvaccinated individuals. This dotted blue line represents those individuals who received the primary series of vaccine. And then this dark blue represents those individuals that got the booster dose included. So compared to people who've had vaccinated, those who are unvaccinated have much higher rates of getting infected. And those who have gotten the primary vaccine but did not have a booster did not get had a higher rate of getting infection as well. It's not to say that getting all the vaccines will protect you totally. There's really no vaccine that works 100%. So we do see disease in individuals who have been fully vaccinated with a booster, but the disease tends to be much milder. And you can see really here, if you look at the worst outcome, which is death, you can see here that the difference between those who are unvaccinated have a significantly higher chance of dying from their infection than those who have been fully vaccinated or up to date with a booster. This has really withstood the test of time since vaccines first became available, and is really certainly very important when you consider whether to get the vaccine or not. Similarly, when you look at hospitalizations, a similar type of spread between individuals who are unvaccinated versus those who are vaccinated or fully vaccinated with a booster. Those who've gotten the booster have better outcomes, less severe disease. If they do get disease, it's less severe than these other groups here. So less risk of complications, less risk of death if you receive the vaccine. And this is just another slide which outlines that the risk for unvaccinated individuals is consistent through all age groups. So it may range from 2, but it goes up to 8 times higher. So that's really been a very important outcome from our vaccinations, and has been one where should prompt people to get the vaccine. But if you look at the map of the United States, this is looking at people who have been fully vaccinated. Remember, fully vaccinated is completing the primary series. We are New Jersey, so 75% of citizens in New Jersey have gotten at least 1 dose of Johnson & Johnson or 2 doses of the messenger RNA. But you can see that there are areas of the country where the vaccine, fully vaccinated individuals is below 60%, around 50, 56%. And so these individuals can certainly be susceptible to infection. If you look at those percentages that receive booster, it's even less. So in New Jersey, 35% of people received the booster dose, but you can see that the overall uptake of booster doses is much, much less than what we saw with the primary series. So now in the news is the question about a 4th shot, and why is there talk about a 4th shot? So the concern is that immunity wanes over time. Our ability to protect ourselves from getting infected decreases over time. And this is true whether you got vaccinated or whether you had COVID infection itself. Meaning that if I had a COVID infection and 4 or 5 months later I was exposed to a new strain of the COVID virus, I can get infected again. So regardless of whether it's due to natural infection or vaccination, our protection will decrease over time. So with the 4th dose, this has mainly come out of Israel and looked at, they started administering a 4th dose to people aged over 60 and those who are immunocompromised. And at least initially, and this is very preliminary data, that the 4th dose reduced the risk of infection by 2-fold and the risk of severe illness by at least 4-fold. So some benefit, but remember, this is specifically for populations who are at higher risk for complications. When they looked, they did a study in healthcare workers, and while it boosted the antibody levels to previous levels that were seen in these individuals, it doesn't seem to provide as much protection against infection as it does in the higher risk groups. So the Pfizer and Moderna have both requested FDA approval for 4th dose. Their requests are slightly different. Pfizer is just for those 65 years of age or older, and Moderna requested approval for a booster for all adults. There are a lot of considerations need to go into this. One is what populations would benefit the most from an additional booster. So do we just give it to our high-risk populations, those who are most at risk for having a hospitalization or death from the infection, or do you give it to everyone? And then what's the optimal timing? So we know we're in a lull right now, so do we give a booster now? But what if the next surge occurs in 6 months? Will that booster still provide protection 6 months from now? So understanding what is the optimal timing is something that needs to be learned as we go along. England, as of yesterday, just started recommending a second booster dose for anyone over 75 years of age and those who have suppressed immune systems, and those residing in nursing homes. Again, they have restricted or narrowed the booster recommendations to those individuals who are at highest risk for complications. And then finally, I just want to talk about this community risk levels. This was something that the CDC kind of changed a couple of weeks ago in community. So you can see the difference. One map is green, one map has orange and red to it. You know, what's the difference between the two? So this is just showing the amount of disease in the community, how many new cases there are, and what percent of the population who get tested for COVID test positive. It doesn't tell you how severe the disease is, it doesn't tell you whether it's mild or severe. It's really strictly on disease prevalence or the frequency of disease in the community. And this was what had governed mask recommendations in the past. What they've done now is really focusing on not necessarily how much disease there is in the community, but how severe it is and what impact that has on individuals in terms of hospitalizations and what impact that has on our healthcare systems. And if it does not have a significant impact, then the risk for complications is lower. And so when they have green, they have recommendations about, not being as recommending masking as they would if they were yellow or orange, like in some of these areas that you see in the map. So this is really driven by how severe the disease is appearing in individuals and what impact it has in our hospitals. And that just, I think, I repeat in this slide. So what do you do? So if it's low, the recommendation is, stay up to date with your COVID vaccine, get tested if you have symptoms, don't go to work if you're symptomatic. In the medium risk scenario, it's when you should start, if you are at risk for severe illness, talk about, whether you need to wear a mask or take other precautions that you may have done in the past. And then if it's high is when it's going back to masking indoors in public. We have relaxed all our masking guidelines in most of the country because of the low severity of disease right now. But we have to recognize that we may be flexing up and down based upon what the virus does. Now, I will say, going back to this slide, if you are someone who's very concerned, right? If you have, you're severely immunocompromised, or you just don't want to get the virus infection no matter what, I would focus on this one because this tells you what's happening in your community. And so, I'd be, if I had that amount of concern, if I was orange or yellow, then I would probably be masking indoors as opposed to if I was blue. And here, I think, is, if you're willing to accept some risk to getting infected, but understanding that the impact is probably going to be mild, then that's where this map comes into play, and the masking guidelines can be relaxed more. And hopefully that made a bit of sense. And then this, this is just on the CDC site, and it just talks about the different interventions between low and medium and high. And we have set something up similar in our hospitals. And again, we just want to flex up and down. We don't want to say, we don't want to make decisions about and try to cause, we don't want to cause confusion. We want people to understand what to expect when disease is at a certain level in our health system. And I think this is an attempt to really do the same in our communities and population at large. It's an opportunity to flex up and down based upon disease activity. And then finally, the booster. If you've been fully vaccinated, I certainly encourage you to get your third shot or your second shot if it was J&J to really provide protection because COVID is not gone. And remember, we still have 1,000 cases occurring in New Jersey. And we do not know yet what will come in the future. We may remain like this for a while, forever, or we may see increases again. So the virus, as we've learned, dictates its own course rather than we dictate the course of the virus. And I think that was it. I'll stop sharing and throw it back to you, Melanie.
Thank you so much.
I just want to jump in, just one quick
ahead.
comment.
Mm-hmm.
First of all, I just want to thank Dr. Zuckerman again for his leadership on this issue, both for our group, but also certainly for our health system. And I just wanted to highlight, again, I think for, a lot of us have gotten vaccines over the years, and we probably didn't think a whole lot about how effective they are. Sometimes people criticize the flu vaccine because, it's only 60% effective or 50% effective some years. And I just want to, highlight again that Dr. Zuckerman made the point a little while ago about the really impressive benefit in terms of preventing death, about a 20 times reduction in the risk of death. And again, you're talking about a disease that's very close to killing 1 million Americans. And so really impressive in its effectiveness, and also I would say impressive in safety. And I'm not trying to get into all the politics of vaccines and all. It's just, again, I think most of us don't think about vaccines. Certainly, most people, they get their shots to go to school and they don't think about them a whole lot. But, for somebody, an infectious disease professional like Dr. Zuckerman, and for me working with, large populations and trying to care for our patients, we do think about vaccines a lot. And it's just really, it's still kind of amazing to me that, 2 years after the pandemic, we have such extraordinarily effective and, really a great safety record for the vaccines that are available. So it's we should be very thankful. Whatever you think about your own personal decisions about vaccines, you should be thankful for the community at large that we have such effective vaccines available to our population. So thanks, Melanie. I'll leave it there.
Mm-hmm. Okay. All right, so we're going to open it up to the audience. If you have any questions, please add them to the chat. And while you do that, I'm going to jump into some prepared questions we've collected from staff members and participants. All right, so a couple of questions regarding vaccines and pregnancy. Should a pregnant woman receive the vaccine at a certain point in her pregnancy, or does it not matter?
So the recommendation from the OBGYN and midwifery community, as well as, I'd say general recommendations from physicians and infectious disease specialists, is that a woman, if she isn't vaccinated and she becomes pregnant, she should get vaccinated as soon as possible. There's no perfect time in the pregnancy that you should wait until 4 weeks or wait until 20 weeks, and really just get vaccinated as soon as possible. The vaccines have demonstrated safety in pregnancy, and this disease, which is, can be devastating to a lot of different populations, has been demonstrated to show worse impact on pregnant women, not only to the woman's health, which obviously is bad enough in itself, but in addition, it can lead to pregnancy complications such as preterm labor. So for all those reasons, you want to have the protection as soon as possible. And so if a woman hasn't received her vaccines, or she isn't fully vaccinated, or hasn't been boosted, then she should go ahead and get vaccinated really as soon as she reasonably can.
And a question from our audience: is the potential new surge the same level of severity of the latest variant?
Yeah, so that's a very good question, and one we really don't have an answer to, but these are the things that to consider. So, we know a large part of our population has either been vaccinated or have had an infection. So we, unlike, beginning of 2020, when every single one of us was totally susceptible to this because we'd never seen this, we have a large percent of the population has some immunity to the virus. The caveats being, one, as I mentioned earlier, is that the immunity, that level of protection tends to decrease over time, right? So if I had a Omicron infection in January, then an impact of a new variant may be much lower than if I had the Alpha variant a year ago, or if I got vaccinated last spring instead of this spring. So the farther you go out, potentially the more vulnerable you are for getting a new infection. The severity of that depends on how the virus changes. So if the virus changes in such a way that whatever little protection that we may have remaining doesn't do anything, then it may cause severe disease. It also depends upon whether you have other medical conditions. So we know with something like flu, people who are very old or people who have heart disease or cancer will have more likely have complications, even if they've been vaccinated, than someone who doesn't. And so that can certainly occur with a COVID infection. It can exacerbate some of these other conditions. So it's difficult to know exactly what's going to transpire. Right now, the subvariant does not seem to cause any new disease or severe disease compared to the one we saw circulating a couple months ago. And in terms of hospitalizations, they've only seen an increase in England, and not have seen a concomitant increase in Italy or Germany, which I think is somewhat encouraging, meaning that people are getting infected, but without necessarily the severity of infection.
How strong is COVID immunity in the newborn baby of a vaccinated mother? How long does it last?
So I don't know the specifics of the immunity for newborns. What I would say is a couple of things. So number one is, it's the only protection we have for newborns. So it may not, almost certainly it's not as effective as vaccination or, God forbid, an infection. However, it's the only thing that we have in terms of protection. In terms of its duration, typically the proteins, the antibodies, obviously the baby's not producing antibodies. The antibodies are being received passively through the breast milk. And so those proteins get broken down over months. So, a baby that is breastfed for, a month or 6 weeks would have benefit for several months after that. So, it's some degree of protection. It's probably not as effective as a vaccine or natural infection, and it lasts for, certainly during breastfeeding, but even after breastfeeding, it would last for weeks to months after that.
What is the latest information on a vaccine for children under the age of 5?
Yeah, so that's still, we're still waiting to hear. They initially applied for approval, but decided to wait for more data to come in. And so what they were basing their approval process was on the effectiveness of the vaccine after 2 shots. But what we've seen, with the adult experience and stuff, that really protection is best with a 3-shot series. And so rather than, get it approved for a 2-dose series and then go and add a 3rd dose to it, the companies and the FDA said, let's put it on pause. Let's find out what the whole series looks like in terms of efficacy, and then go through the approval process. So I suspect that it'll be in a couple of months when that data will be presented to the FDA, but right now it's still on a pause.
How common is myocarditis in children who get the vaccine, and is it treatable?
Yeah, so that was one of the slides I showed. It's not mainly it's in young male, young adolescent and young adult males is the highest risk. And again, it can range from 40 cases per 1 million. Again, that's 1 million doses, or up to 100 cases per 1 million. So it's a very small portion, potential for that type of reaction. Um, the the infection or the inflammation of the heart muscles, it resolves. This is not permanent damage to the heart. It tends to resolve with over time, over a few days to a week. Sometimes people are hospitalized for a few days, but it's really a temporary thing and not a permanent inflammation of the heart muscle.
I think yes. The question was specifically about treatment. I don't think there's a whole lot of treatment. As you said, Dr. Zuckerman, it's just time alone.
Yeah.
It tends to resolve on its own.
Well, yeah, and they think steroids can help decrease the inflammation. So that would be the only treatment that someone would get.
Thank you. In addition to vaccines, what other technologies are being developed to treat or prevent COVID?
So I'm not sure what else other than vaccine. Well, so there are a couple of therapeutics. So if you have infection, there are a couple of ways that you can treat someone to help prevent that person from going on to a severe infection. And so this is before anyone gets in the hospital. So there are a couple of oral pills that you can take by mouth that recently came out, and that will help prevent the infection from moving forward, will help eradicate the virus, kill the virus. So those are available and are becoming more readily available. So, as with everything that's being first produced, it was in very limited supplies, but has become much more available in our retail pharmacies. The other treatment is called a monoclonal antibody. So essentially, what it's giving us is a protein, an antibody to fight off the infection, similar to the antibody that we would produce if we were vaccinated, except that this is being administered through an IV and giving you very high levels of the antibody to help keep the infection in check. So those are two treatment options, and generally they're recommended for individuals who fall into a risk group where they have a higher risk for progression of disease or progression to hospitalization. Those would be elderly individuals or immunocompromised individuals. A young, healthy adult, most likely it would not be recommended for.
Particularly for those who are vaccinated, correct, Dr. Zuckerman?
Yeah. And then the other thing that's available now, it's also one of those monoclonal antibodies. And it can be given to individuals, and it's for individuals who don't have a very good immune system. And those antibodies can last for up to 6 months to help prevent from getting an infection.
I'll be there in a minute.
So it's another way to augment our protection. And additional to vaccine, it's giving those very high-risk individuals additional antibodies to afford some protection. So those are really the only other options for treatment directly of the virus or prevention of the virus as an outpatient.
Do you recommend continued mask wearing in certain environments? And if so, which environments?
So I do think it again, you have to check the environment out, right? So right now, I think our Diseases in the community as low as it's been for months. So I think there's much lower risk. Um, an individual needs to assess their own risk tolerance here. Um, so, if I had a transplanted kidney and I was 70, I probably would be seriously considering never taking off my mask. But if I'm 25 and have no other medical conditions, then I think right now where we are in the state of things, that it's more reasonable to take off a mask. And I think that's where the red, green, yellow, and red can help guide some of this decision making. Even though I think we've all, the states and the schools have all relaxed their masking guidance, it is a personal choice as to whether one wants to consider or continue to wear a mask. So, we finally, not in our hospitals, but in our offices, or like our administrative offices in our network, where there's no patients or anything. This past week we said, masking is optional in the office. So, we again go up and down depending on what's happening in the community, and what your individual risk factors are.
Thank you. How close are we to reaching herd immunity?
Well, I think that gets back to the question that was asked earlier: is what is the what's going to be the impact of a new surge? We're there. I mean, there won't be herd immunity because the virus changes and because our immunity levels decrease with time. So that concept of, it's not like measles, where if you get measles or you get the vaccine, you're protected from life, right? And that's why measles is disappearing from the world. It's more like influenza, where each year, the virus changes a little bit. So a new vaccine comes out, you get a vaccine for that year, but the vaccine only lasts for a year because your immune system, immunity declines over time. So you get another shot a year later. So I think what's going to happen is we'll probably see a model closer to that than what we saw with measles or polio and totally eradicated from the world.
Yeah, I think it's fair to say that the idea of herd immunity, which was something that we talked a lot about in 2020, it probably is not going to apply to coronavirus, as Dr. Zuckerman said, both because of the remarkable ability, which is true of both viruses, but I mean, the coronaviruses are particularly known for being very adept at changing regularly, as we've experienced with going from Alpha to Delta to Omicron, and now the new Omicron variant. And the fact that our immunity to many viruses, including the coronavirus, is not as durable as we would hope. So I think for both those reasons, it's probably going to be a situation where we're not going to be able to rely on herd immunity. And I think the mere fact that in the United States, where we have pretty good vaccination, 75%, and not very good boosters, and where a lot of people have gotten the disease, we still see one of Dr. Zuckerman's slides still showed an increase in the transmission rate. So that suggests to me that even with a lot of people either naturally immune or having received the vaccine, we're still able to transmit the virus around our population. So I don't think we're going to get to herd immunity.
And I just want to say, I think I'll use this as an example of how some of the public trust has been eroded over this. So if you remember, back when vaccines first came out, everybody was talking about herd immunity. People were saying, well, if we get to 50, 75%, 90%, we'll all be protected, it'll go away. That's what we're striving to do. And that was based on what we knew at the time. But as you mentioned at the beginning of this, every day there's new information coming in. I mean, this virus has only existed for 2 years. And so, we need to continue to adapt and be flexible and adjust our protocols and recommendations as we learn more. and we got to be better able to communicate that, right? To me, it's no longer black or white, right? There's a lot of gray here, and it's trying to give the best advice on the information we have available at that time, and what we've learned. I think that's a lesson that the public health community, hopefully we've all learned in terms of messaging, because it doesn't bode, it doesn't allow much trust if I tell you one thing and then it never happens, right? So I think it's important to be modest and recognize that we are learning, and to communicate that with the general population, as they're going to be learning with us.
Okay, so we are nearing the end. If anybody else has any questions they would like to ask, try to get them in the chat. I have a question from the presentation. It was so interesting to see all of those graphs and charts. I think I became kind of graph fatigued after a while, but to see them again was really interesting. And you had showed one graph that broke out, and I can't remember if it was cases or hospitalizations by race. And this is a self-interested question. The lowest line was the Asian population, and I'm just wondering, do we know anything yet, if the graph was in fact about cases, about why it's affecting different races differently?
Yeah, that's a tough one. There's so many variables that are involved with that. So, different populations have different co-medical conditions, right? So, if a population or ethnicity has a higher rate of heart disease than others, they're more likely to have complications when they get infected than someone who doesn't. It also can be reflective of socioeconomic status and demographics. If you don't have access to healthcare or or heat or food, those will all impact your outcomes. And then also, it's and then it's your individual risk behaviors. And I don't know if one ethnicity has more risk than another, but it's just very broad. I don't think there's anything in terms of genetics that protects one group over another, but I think it's a compilation of all these things that put some individuals at higher risk than other individuals.
Thank you.